Okay. All right, so like I said, I'm covering management of hypertension in the Pacu. So let's cover a little bit about, what is the definition of hypertension, at least the agreed upon definitions that are most recent by the ACC and AHA are hypertension occurring with systolic blood pressures that are 130, greater than 130 to up to 139, or diastolics 80 to 89. And you've got, this is supposed to say stage 2, if you have systolics greater than 140 or diastolics greater than 90. And remember, the diagnosis of having hypertension is supposed to be performed with at least two separate readings of blood pressure. And those separate readings, you also want to have them at two separate instances. So maybe you're seen in a patient is seen in clinic 1 month and then has a follow-up, and it has another pair of readings. And it's the average of those that lets you see which category they should fall into. And then if you, let's say they have a normal systolic, but an elevated diastolic, or vice versa, and one would put them in stage 2 and the other one would put them in stage 1, you always want to designate them with the higher of the two, the riskier of the two. And then importantly, if you have a patient with systolics above 180 or diastolics greater than or equal to 120, but they don't have signs of end organ damage, like they're not having severe headaches, strokes, kidney injury, liver injury, what have you, then that gets designated as a hypertensive urgency. But as soon as you get those signs of end organ damage, you cross into hypertensive emergency. Now, a hypertensive urgency can be treated with oral medications, but a hypertensive emergency, that is severe enough to require bringing down your blood pressure with IV antihypertensives. So shifting a little bit to more of the PACU setting, post-operative hypertension, we're used to seeing, I'm sure all of you are familiar with seeing patients with nausea or respiratory difficulties. Those are probably more common than hypertension in the PACU, but it's still a very common problem. And many patients will experience hypertension in the PACU starting anywhere within 30 minutes after the completion of their surgery, and it can last upwards of 2 hours post-operatively. And it's been shown to affect approximately up to 80% of cardiac patients, cardiac surgery patients, as well as greater than 25% of patients undergoing major non-cardiac procedures. So it's fairly common, and many patients are at risk for this, but especially if it's a patient, not surprisingly, who is already hypertensive at baseline. Whether or not they're on antihypertensive medications, if they have a diagnosis of hypertension or should have a diagnosis of hypertension, they are more likely to have post-operative hypertension. But importantly, not all patients will require treatment. And so just thinking about the common causes of post-operative hypertension. So one way in which we see hypertension evolving is as a result of increased sympathetic activity. And this can be from nociceptive input from the surgery itself, so pain. You can have, by having surgery, your patient is going to have release of catecholamine, serotonin, renin, all of those molecules are going to be really flowing around and leading to increased blood pressure. You can also see problems with if you have a patient with severe urinary retention and their bladder is distended, you not only have pain or nociception, you can have increased renin secretion through that as well. Or if you have a patient who maybe got a lot of fluid resuscitation or is not tolerant of a lot of fluid resuscitation, they can have hypertension as a result of fluid overload. And I won't go through the physiology of this, but in patients with elevated intracranial pressure, it directly correlates with mean arterial pressure. So if you have higher intracranial pressure, you're also going to have higher mean arterial pressure. And then there are many patients who are on daily antihypertensives and are told that they can't take a specific one. Notably, we tell patients that they can't take ACE inhibitors, for example. And so maybe there's someone who is now kind of withdrawing from that, or maybe they usually have like a clonidine patch and we're told that they shouldn't take their clonidine preoperatively. So now they are someone who is missing their baseline antihypertensive coverage. So they may then, after surgery, be much more responsive to all that sympathetic activity we talked about. You can also have patients with spinal cord injury who have autonomic dysreflexia. You can have carotid surgery that interferes with the baroreceptors, pheochromocytoma, thyroid dysfunction, and then hypothermia can also lead to increased sympathetic activity that will lead to hypertension. Oh, and I didn't have it here, but shivering can also lead to hypertension. So why do we care about post-op hypertension? Why is this important? If you have elevated blood pressures, that means your heart is going to be working harder to fight against the elevated systemic vascular resistance. And that can lead to increased cardiac oxygen demand. So the myocardium needs more oxygen in order to keep up with the pumping that it's doing. And this can, if it's not able to get enough oxygen to meet that demand, you can get ischemia, so you can get an MI. You can also get heart failure and depressed left ventricular function. You can have any variety of cerebrovascular accidents. You could have a hemorrhage, you could have an aneurysm burst, you could have, it can lead to arrhythmias, and you can also have the actual suture lines that the surgeons put in can become disrupted, and that can lead to a whole host of other problems, not just bleeding. So how do we approach treating hypertension in the Pacu? As I'm sure you're all well aware, we are trying to keep our patients either at a normal physiologic range, whatever we predefined as normal, or if their baseline isn't normal, we want to keep them within 20% of their baseline. Like, we've all had patients who surprisingly live fairly comfortably with systolics of like 185 and diastolics of like 110, and you see that and you're pretty concerned, and it's not good for them, don't get me wrong, but that's their normal. We don't want to drop them to a pressure of like 120/80, because then they might not be perfused. Their body has grown accustomed to that high level of pressure, so then maybe they're not able to perfuse their brain as well if you drop them that low. So that's why we want to keep them within, our guidelines are 20%, but many places will also say 20 to 30% of their baseline. And so prior to jumping into giving people IV or PO antihypertensives, you also want to search for reversible causes of hypertension. So are they in pain? Is their bladder distended? Do they need an ISC? Are they fluid overloaded? Do we need to give them a diuretic? Is the monitor itself working appropriately or as expected? Should we move the cuff to a different place? Is the cuff the right size? If we're following an arterial line for blood pressure, has it been zeroed? Is it at an appropriate level for our target organ? Like, is it at heart level, brain level, whichever thing we're most interested in? And if after we do all of those things, we're still not able to relieve this patient's pressure problem, then we can move into those pharmacologic interventions that I'll talk about. And for this talk, I'm mostly going to focus on IV beta blockers and calcium channel blockers with specific focus on a new, clovidipine is a new medication I guess it's been around since or like 2008, 2009, but it's been here at Michigan mostly used in the ICU and is now being available here for use in the PACU. So I'll focus on that in particular. So if we wanted to give our patients beta blockers for to correct their hypertension, there are a few that we use, but primarily we use labetalol. Labetalol is one that you guys are probably most familiar with. It works by blocking beta adrenergic receptors non-selectively. So it blocks beta 1 in the heart and beta 2 elsewhere in the heart and in the periphery. It also blocks alpha 1 receptors, and it's the alpha 1 that brings down the systemic vascular resistance, and it through beta actions, it kind of slows down the heart rate, and that also decreases blood pressure. Sometimes we do have the ability to use asmol and metoprolol, but because their actions are more beta 1 oriented, which that's going to mostly affect heart rate, and you don't always want to bring down a patient's heart rate, and they'll have less robust effects on pressure than labetalol will. So labetalol is pretty fast onset. It can take about 5 minutes for you to see a clear effect from it. And it lasts a pretty long time. It can last 5.5 hours. So it continue to have, 5.5 hours for a half-life. So it can continue to have effects for several hours afterwards. And dosing, you're doing 5 to 10 milligrams, and you can do that as frequently as 5 to 10 minutes. Let's see, hydralazine is another, back to labetalol. Labetalol is, really useful, but there are times that you don't want to use it when a patient's heart rate is lower. That's not an absolute contraindication, but it's something to keep in mind that you don't want to drive their heart rate too far down. But if there's someone who's used to taking beta blockers already, they may not be as sensitive to those heart slowing effects of labetalol. Also, because it's a non-specific beta blocker, you may have, you want to be cautious using this in a patient with a history of asthma, because this can exacerbate their asthma. So alternatively, if you have a patient with asthma, or you have a patient who is bradycardic, but or more on the bradycardic side, but still hypertensive, you can think about hydralazine, which actually will have the opposite effect on heart rate. You'll get more tachycardia with hydralazine. And it works by relaxing arteriolar smooth muscle. So that is going to work after the heart. And so that will decrease the afterload that the heart is seeing. And so that's also pretty fast, also lasts a fair amount of time, and has sort of similar dosing as labetalol. And now, if these first-line approaches aren't successful, or they have certain contraindications, then we want to look at IV calcium channel blockers. And one that you'll often see people come out on infusions for is nicardipine. Nicardipine works pretty quickly. It can start working in 5 to 15 minutes, and it is fairly, short duration, where within about 30 minutes, you'll see about 50% of its activity diminished. And it's metabolized in the liver, and its dosing, you start at 2.5 or up to 5 milligrams per hour. And you're going to titrate this by looking at it and changing it every 15 minutes. So, and you have a max dose of 15 milligrams an hour. And this is a medication that needs to be given through central access. Now, let's talk a little bit about clofidipine. So clofidipine, I went to the pharmacy this morning and I got pictures, so you guys will know what it looks like. It comes in a box. I don't know if they'll give it to you in the box or not, but this is the box. And here's the little bottle, like kind of reminiscent of like the IV Tylenol bottles. And it has a concentration of 0.5 milligrams per mil. It's a 50 ml bottle, and the entire bottle contains 25 milligrams of clofidipine in it. Clofidipine is a dihydropyridine calcium channel blocker. It leads to arteriolar smooth muscle relaxation, And this one is cool because it's really ultra fast. Its onset is very quick, and it's metabolized by plasma and tissue esterases. So it does not rely on the liver, and it does not rely on the kidney. So it's quick onset and it's quick offset. And so it can be very quickly titrated, and you don't have to worry about its use in liver failure patients or patients with liver or kidney problems. So it can be pretty widely used if necessary. And unlike other medications like, let's see, like nitroglycerin or nitroprusside, it does not decrease preload. It focuses mostly on afterload. But people you don't want to use this in. So it's made in a lipid emulsion. So you have to be cautious with patients who have a soy allergy or an egg allergy. Also, because there's so much lipid content in it, you have to be cautious with patients who may have defective lipid metabolism, because they might get like overloaded with lipid and their body might not be able to handle it. Also, because there's such significant decrease in afterload, patients like with severe aortic stenosis who depend on their afterload in order to get good coronary perfusion, they're afterload dependent. If you take away their afterload, they're not going to perfuse their coronaries and they could have an MI. So you have to be very cautious with that in patients with severe aortic stenosis. So comparing nicardipine and clofidipine, clofidipine is faster. It just in minutes, you can have onset, offset in 5 to 15 minutes. And dosing for this, you start with 1 to 2 milligrams per hour, and every 90 seconds, you can double the dose. And so it's a doubling effect. So let's say you're doing, you start at 1 milligram per hour at time 0, at 90 seconds, you'd go to 2 if you hadn't met your goal yet. If you're still not at goal 90 seconds later, then you would go to 4. And if you're still not at goal, then you would go to 8 and so forth. But you want to have a maximum dose of 16 milligrams per hour. And you don't want to give a patient more than a liter of this in a 24-hour period because of that lipid content. And unlike nicardipine, this can be given centrally or peripherally. So that's really handy in patients where they don't have a central line, but we need to get their blood pressure down fast. So some important storage things to consider. Clofidipine is photosensitive, and so you want to be cautious with its exposure to light for prolonged periods of time. You also don't want to, it's refrigerated for longer term storage. Once you bring it out of refrigeration, for sitting at room temperature, you don't want to return it back to refrigeration. And then once you've opened it, essentially, you want to use it within 12 hours and make sure you're gently inverting it because it's in that lipid emulsion. You want to make sure that it is homogeneous. And as far as compatibility with site compatibility with D5W, D5NS, D5LR, NS, and LR. So it's pretty widely compatible. So from my part of the presentation, take-home points: hypertension is a common problem in the Pacu. We want to look for easily reversible causes, though not everyone needs treatment for hypertension. We do have IV medications available, and IV clofidipine is a fast and safe second-line option. Any hypertension questions or clofidipine questions? Yeah.
Why does it seem like I've been a nurse for a long time?
Sure.
Worked in a practice for a long time. And I know the first line of defense is pretty much labetalol.
Yeah.
But it never seems like it works well. It seems, I mean, I'm not all the time, but majority of the time, and it seems like when they get hydrolysine, it seems to work better, you know?
Yeah. Well, and since they work on different mechanisms, it's possible, that's a very good question. It's possible that we haven't quite keyed into what their problem is. Maybe we just needed to try it from a different avenue. Also, in this kind of scenario that you just described, we've given them labetalol And now we're also giving them hydralazine. Sometimes people kind of need two different avenues, kind of the same way we approach pain multimodally. Sometimes patients will need like different avenues attacking the same problem. But yeah, and some it could be a threshold dosing issue as well. Like maybe we aren't giving them a high enough dose of labetalol to begin with. And so maybe that's part of why you need this other avenue. But really good question. Anything else? Okay, let me get Carl set up.
Well done.
Thank you. Okay, and then let's see, I'm not quite sure where yours is. Is it? Where was yours?
Right here.
Okay, so then you'll have to. Okay, so you want. Okay, look here, I'll let you take over.
Yeah.
All right. Maybe.
So screen sharing.
It's back here too. Yeah. I think so, maybe.
I just opened it from my email.
Huh. It should work.
No, have to. Oh. Yeah.
From that, then I share.
If I share, you share first.
So share, yeah, share screen first.
Oh.
Okay. You good?
Yeah, like Arn said, my name's Carl. It's been nice to meet you all and work with you during the beginning of my CA1 and these 2 weeks in PACU. And I'll be talking about hypotension in the PACU, but it's a pretty broad topic of just hypotension. And so this is kind of the way I like to approach it, is just kind of take a step back, think about the physics of, what is the blood pressure using Ohm's law. So physiologically, the mean arterial pressure is equal to cardiac output times the systemic vascular resistance. And then I just kind of work through, the components of cardiac output and things that could affect systemic vascular resistance. And so for my presentation, I've got 4 cases. Feel free to interrupt at any time. You can shout out the answer or share a story of a similar experience that you've had. Meant to be just pretty interactive. So, think about cardiac output. The two things that the 2 components of cardiac output: stroke volume and heart rate. And the heart rate could be a fast, irregular beat that's causing the decreased cardiac output, and stroke volume could be preload. Did they have a lot of bleeding intra-op? Have they been NPO for like literally 24 hours and poorly resuscitated? And then the contractility of their heart. How is their heart functioning? And lastly, afterload, which is very similar to SVR, which is essentially the same as SVR. So the first case, this is a 33-year-old guy, pretty healthy, ASA1E. He's 65 kilograms, came into the ED by EMS after a motor vehicle accident. His exam, he's got a seatbelt sign, which you can see over here. His abdomen's distended and tender. So he's taken to the OR for an X-lap and ultimately a partial small bowel resection. Surgery went well. He's brought to the PACU. His vitals are all good. He's 37 degrees Celsius, 112 over 73. His heart rate's 71, and he's satting just fine. Everything's fine, but after about 10 minutes, he becomes a little bit more awake. He's complaining of 10 out of 10 pain. He's kind of writhing there in the bed and looks super uncomfortable. The new CA1 resident, me, Carl, failed to include pain management medications in the PACU orders. So you page him, and he comes to bedside. He pushes 10 milligrams of morphine and then walks away. Yeah, I know. So then the blood pressure cuff cycles. It's now reading 73 over 42. Yeah. So what do we think happened here? Yeah. So decrease in the SVR. And so some of the things that can cause the decrease in the SVR, it's definitely medications. I just used an example of a ton of morphine very quickly causing that. Propofol, other anesthetic agents that we have that might still be floating around in our patients as they come to PACU. It might be a little hypotensive. I think we've all seen that. Sepsis, do they have an infection? Did they just come from the IR and have kind of some urosepsis, just gets spewed all around? Do they have a fracture to a C-spine leading to neurogenic shock and decreased SBR due to a neurogenic component? Did we just give them an antibiotic that they're allergic to and they have urticaria everywhere and now they're in anaphylaxis? So these are kind of some pretty common things that can cause a decrease in the SBR, decrease in the afterload, leading to hypotension. All right, case number 2. This is a 65-year-old ASA 3, no gender, so we'll just say a male, is now status post right knee arthroplasty that was done under a spinal anesthetic. He's transported to the PACU. The surgery and anesthesia residents don't have any immediate concerns, but the patient's delirious, moving and lifting his legs. The monitors are placed on him. He's profoundly bradycardic at 36 beats per minute, and the blood pressure cuffs reading 76 over 46. You alert the distracted anesthesia resident who's trying to catch up with their charting. They frantically administer some glycopyrrolate. The patient's heart rate increases to 76, and his blood pressure is 124 over 80. So this is an example of a spinal anesthetic. The patient's kind of moving their legs. The spinal anesthetic goes higher than what we would want to the cardio accelerator. To the cardio accelerator fibers, blocking those. So then you have basically unopposed parasympathetic effects going to the heart. This can be seen also like if the patient's in Trendelenburg for whatever reason, but they had a spinal anesthetic that can lead to this as well, high spinal. And so, correcting this with glycopyrrolate, just supporting the patient as the anesthetic wears off. And so, that was an example of the change in heart rate leading to a decrease in cardiac output, leading to hypotension. So some other things that can cause bradycardia is medications. Opioids can cause bradycardia. Are they, profoundly beta blocked, and now they can't support their blood pressure due to their beta blockade? Do they have a new AV block? Are they now a complete heart block and in cardiogenic shock, and they're, having long pauses? Did they take way too much of their digoxin, which is the Starry Night picture, which can also cause AV block? And also things that, just bradycardia is one cause of hypotension, but even a fast heart rate, AFib with RVR we see, and their pressures tank. So is that the reason for the decreased cardiac output, ultimately the hypotension? All right, case 3, 60-year-old female, 70 kilograms, ASA 4, brought to PACU after a craniotomy for aneurysmal clipping. The case started at 8:30. She's been NPO since 8:30 p.m. the previous night. We'll say the case was like 4 to 6 hours. She received mannitol during the case. Intra-op fluids include 1.8 liters of crystalloid. Urine output was 2.2 liters. UVL was 500. On arrival to the PACU, her vitals were 36.0, 98 beats per minute, 98 over 60, and SpO2 of 95% on 2 liters nasal cannula. The surgery team ordered 50 cc's of LR for maintenance IV fluid. While on the PACU, she progressively becomes more hypotensive, and BP is currently 88/50, and the heart rate's 105. What do we think the cause of her hypotension is? Yeah, super dry. So she's been NPO for for a very long time. She receives an osmotic diuretic in the OR. So her urine output was 2.2 liters, and she was inadequately resuscitated. So really, she's probably down like 3 liters, and that's the cause of her hypotension, which would be a decrease in preload. So that could be caused from increase in EBL in the OR. On this X-ray over here shows a tension pneumothorax on the right side, clamping down on the IVC. There's no blood going to the heart. They don't have any volume going into the heart, so there's not going to be any volume coming out of the heart. And then the ultrasound below shows a cardiac tamponade, and kind of similar to the tension pneumo, unable to load the heart with any volume, and thus nothing's going to come out of the heart. Case 4, our final case, 68-year-old male, ASA 3, 80 kilograms, has a history of medically managed coronary artery disease, hypertension, sleep apnea, had an elective hernia repair under GA. The procedure was completed without complications. There is a PACU and is hemodynamically stable. He's about to go to phase 2 when he has acute chest pain. Now he's diaphoretic. You alert the PACU resident. You look at the five lead EKG. There's new ST elevations. Blood pressure is 80/44. The PACU resident is waiting for a stat EKG and troponins. So while he's waiting, he places an ultrasound probe for a bedside echo and shows this heart that's really not pumping at all. There's no contractility to that left ventricle, and thus is the cardiac output is almost nothing. And that's due to poor contractility. In this case, it was due to likely an acute MI. But other things that can cause a decrease in contractility are volatile anesthetic agents. And then there's the EKG, you can see the STEMI. Do they have heart failure, or do they have poor heart function to begin with? And the stress of surgery and the medications they received reduced their EF even more. And now their EF is 20% less than it already was, and they can't handle that. Also, are they hypocalcemic? We see a lot of people with end-stage renal disease. Is their ICAL at like 1.0, and they just need a lot more calcium to help support their heart. So, that's kind of the way I try to approach hypotension in the PACU, and just even during intern year on the floors in the ICU. But I feel like I can just kind of quickly form a differential and not just kind of treat a number and walk away. So there's a picture of my wife and I at the Grand Canyon in the spring. So any questions? All right, help yourself to cookies as well. Yeah.
Thank you guys for all your time.